least that's what that says. I'd like to call the meeting of the Health and Human Services Board on February 21st at 5 p.m. in room 1284 of the Government Center. Roll call.
Julie Smith.
Present.
Dr. Finley.
Present.
Lisa Lynn.
Present.
Sean Anderson.
Present.
Kathy Leaf.
Present.
Dave Osnes. Greg Telejohn.
Present.
Mike Barkalow. Deb Lindeman.
Present.
We got a quorum. The minutes were distributed with the agenda. If there's no objections or corrections, they'll stand approved as presented. Is there any comments or questions in the minutes? So they'll be approved as presented. Any public comment? Wasn't there just a lot of people here yesterday? Yeah. Business items. We'll welcome our newest member of the Health and Human Services Board. I believe Shar is going to introduce.
Yeah, I had an opportunity to work with Dr. Kathleen Finley. We were looking at doing a grant on holistic medicine. We didn't get the grant, but we had an opportunity to really connect. So we're just going to give you an opportunity to talk a little bit about who you are and what brings you to the board.
Well, thank you. I really appreciate this opportunity to be on the board and serve the community. I grew up in Hammond, so I'm a St. Croix County girl. I left for college, but I married my high school sweetheart and went to medical school at the University of Kansas and got my doctorate in medicine as well as my master's in public health there. I went on to my family medicine residency training in the U.S. Army. My husband was on active duty at the time. So I spent 7 years on active duty as officer in charge of a large troop medical clinic at Fort Sill and then an outpatient clinic in Iraq. I left the Army in 2011, but stayed as an Army wife for the balance of 20 years. I went on to teach public health during that time, and then in preparation for my husband's retirement and return here to Wisconsin, I received my fellowship training in integrative medicine. As we were getting ready to move home, I reached out to Allison Page at the time, and I said, I want to come back to Baldwin Area Medical Center, which I said for years and years I would never do. But I was really excited by the work that they're doing in community health and support of wellness. And so she was brave, and she hired me on, and I started working on developing an integrative medicine program at Western Wisconsin Health. Then this COVID thing hit. I was doing some work in our nursing homes at the time as well, and so I devoted the majority of 8 months totally to nursing home care. So I was medical director for a couple of our nursing homes, providing support for all of what that entailed during COVID. Once things settled down, we started building up the program again, and as of the last year and a half, I've been solely devoted to lifestyle medicine. We have a lifestyle medicine program at Western Wisconsin Health that serves a variety of patients of many different diagnoses and needs, and we have plans to scale to not only within the organization but to the community to support wellness overall. So I'm very focused on population health and have aspirations to continue to grow that at Western Wisconsin Health. I also function in roles as medical director for infection prevention and employee health, bringing into that experience what I've learned in public health and the work that I've done. So I was thrilled when Dr. Anwar asked me if I'd be interested in this position. The health of rural Wisconsin is very important to me. I'm passionate about making sure that we continue to provide top quality care to our region, and I'm very concerned about the current situation. To that end, I went back to school this last year. I'm completing a master's of healthcare delivery science at Dartmouth and doing work with my small group on lifestyle medicine and implementation into rural healthcare. It's something I'll be talking about at some of our national conferences this year. It's just, it is such a real and pressing issue, and I think obviously becoming more and more so as we deal with these realities in our nation. So I'm excited to be here, and I thank you for the opportunity.
Thank you.
Thank you. Welcome. That's all you have. Yeah. Next is Health and Human Services monthly financials. Faye?
So the financials this month that are in your packet are for January of 2024. So when you look at here, we have our brand-new 2024 adopted budget. We have through January of 2024. As I've mentioned in previous meetings, a lot of our expenses that we paid in '24 were posted back to December of 2023. So when you look at that fiscal year '23 column, the second one that's in there, that has changed from last month and will continue to change over the next several months as we have some final expenses that are paid and get in our final state revenues. So we have several final reports that we just submitted that we'll get, and then we'll start reconciliations, and then there'll be some additional funds that come after reconciliation. So all the way up through May of '24, we can expect to receive some 2023 funds. There really isn't anything to point out at this time. As we said in previous meetings, or as I mentioned, currently Health and Human Services is showing a negative balance. We're at a minus $1,855,384. There will be additional funds coming in, but not enough to make up that balance. And then we do have fund balance that we will use to cover that. If we scroll down to the nursing home, so that's on page 26. Again, their '24 balance, they have a positive. The healthcare campus as a whole currently shows a negative $96,000. That does include all of their depreciation, so they fully covered all of their operating expenses, but not the depreciation. There will be some additional adjustments for Wisconsin retirement after the audit is completed for the nursing home. Any questions on the financials?
When we go back up to the first page, I think it is on the interpreter services. Shar, how many different areas are we using the interpreter or interpreters in?
All of the areas in Health and Human Services. All of the areas in Health and Human Services. We have 1.5, well, 1.25. So, yeah, so we have, she's full-time now, but so we have Claudia who assists, she has a job, but that's also part of her job. And then we hired Deanna Bertram, who is now full-time in public health. And that's one of the areas that uses it a lot. So they use, she's working in WIC, but it's also in reproductive health. It's really all of the areas of public health at this point. We use the interpreter quite a bit with our IDPs, intoxicated driver programming coming through, some in our therapy, a lot, probably more within our substance use counseling. It's widely needed.
When we're looking at, it says interpreter services, and it's gone up from roughly 2,900 up to 3,000. What are we talking about for those services for that?
So when you look, the 2022 number was 369. In 2023, we had used 2,886. We budgeted $3,000 for 2024 based on what we were trending in '23. So right now, that looks like a pretty good number, but we'll see.
But that's not for them.
And additionally, and additionally, we use the language line for when staff are off-site. So we have that. Is that what that budget item is for? Yeah.
Yes.
So that would be the language line where they can call and have an interpreter on the line. At the same time, they'll put it on speakerphone and have a conversation.
Will this particular area be impacted by what we're going to be talking about in item number 3? With
Possibly.
The closure
Yeah,
coming up?
possibly.
I would imagine it's going to go way
Yep.
up.
Yep.
What was the majority of the, or I guess, is there one or two key things that is the majority for the negative balance in HHS?
Purchase services for, some of it was our out-of-home placements for children's services, and then on the behavioral health side with Winnebago placements are, yep, those were the, probably there's three primary, 'cause in children's services, we had both child protection and youth justice. Child protection was somewhat higher, youth justices was significantly higher than we budgeted, and the Winnebago was significantly higher than we had budgeted.
Yeah, and those are things we have literally zero control over, so.
Yep.
Winnebago just increased their prices to over $1,400 a day. Yep. Yep, yes.
So that number in that graph that you have there, 468,000, that's what we spent in January?
That, I think, is part of January and February. So this graph pulls through like the current month where our financials only show through so if we look at 52125 on the very first page, it's only 175,650. So this graph is pulling through February.
Okay.
What? Through the date the report was run. So which would include February, because it was run February 15th.
And is that trend, that's going to go this way instead of,
It really depends. I think the only one that's in here right now is Children's Services, EWIS, ACWIS, so those placements get paid right off the bat. So there's almost 2 months worth of placements in that total. Where some of our other ones, CCS is a really big purchase service. Almost all of those are still going back to December of '23. Winnebago, that comes actually through our CARS reporting, or through GEARS now. So that's almost 2 months behind before we'll get those expenses showing.
okay, thank you. Any other questions? Thanks. Next, Shar is going to talk to us about, or discuss with us the impacts of Hospital Sisters Health System closure.
So in January, we were all taken aback. We had no idea it was coming, but January 22nd, there was a press release, and as we found out, many of the employees found out that they were not going to be employed within 1 month. So there was 1,400 people impacted, and probably many of them, like many hospitals, both people worked there, you know, mom and dad, and the gravity is just astounding. I went to the job fair yesterday with HR and Carol Pop. So Carol was there talking about long-term care and trying to recruit some staff. And we have a whole bunch of Health and Human Services staff that needed to be employed, or we're looking for employees. And there was definitely a feeling of despair. I mean, my heart was just like people saying, you know, I'm a pharmacy tech, and there's only so many pharmacy techs, or I'm an x-ray tech, and there's only so many. The nurses, there was hospitals galore at the job fair, but that was just a small, minute amount of people that were impacted. So initially, selfishly, my first thought was, we send so many people to their inpatient hospitalization there, both voluntary and emergency detention. In addition, they took kids 12 and over. So when we now have kids 12, 13, Gunderson will take 14 in La Crosse, which is our closest place to bring our 14-year-olds. That means that too many of our kids are going to end up in Winnebago. Yeah, and we just we have a Minnesota option where if somebody can do a voluntary, we can educate them on getting we'll do like a response plan, a safety plan to get them there. Let us know when you get there, check in, but it's really something that a parent needs to take full control of and getting them there. It's a horrible situation. We're lucky that we're a border state or county, so at least we have that option. We're really pretty close to a whole bunch of hospitals and resources. So that was my first thought, selfishly. My second thought was Ellie Phillips is our only detox center, so it's the only thing that we have local, and they didn't have beds available usually for us. A lot of times what would happen is if somebody really wants to go to residential treatment, they'll have the assessment, we'll do the level of care placement, we'll authorize the payment. If they're not sober, they can't go to treatment. They go to Ellie Phillips first, and then they go to treatment. So now we lost that piece. Our closest detox center, withdrawal management center, is Ashland. There's one in Madison, and I'm Green Bay, I believe. Yep, and that's what we have. And this whole state is competing for these resources. So the ripple effect, I don't know that we even know it yet. What we were told is February 22nd, tomorrow, they go on furlough until March 22nd, and then they're free to work somewhere else. So, like I said, at the job fair, there was numerous people, lots of places looking, which was really a good thing. All from Duluth to La Crosse, there were representatives there. I think we're like this much too far away from Eau Claire to have it be realistic for somebody to not uproot and move. Yeah, it was a little bit maybe too far for some. But the other areas that we didn't think about were birth to 3. So Privia had 19, something like that, clinics where they have occupational therapy, speech therapy, and physical therapy. And they provide that. A lot of that is to birth to 3 kids, to schools, amongst others as well. But those programs rely on those contracts, and so St. Croix, we already have kind of a backup plan because they weren't we have a contract with them, but they're not our main source. Some counties have gotten together and decided to create, share a position. So if they have occupational physical therapy and speech therapy where they're able to purchase enough services from specific people that they can at least continue their services. There's another agency that came in and said, we're going to hire them if you want to contract with us. We have had numerous state, really Northwest Wisconsin conversations about how can we be really smart about this and minimize the impact. Obviously, Chippewa Falls, Chippewa County, Eau Claire County, Dunn County are going to be the most impacted. The first issue was just the emergency rooms, they were inundated. Mayo was inundated with just people in panic. Because the things that I didn't think about were they do cancer care, they do labor and delivery, 900 babies to be born and no place to have them. They also do a primary surgery area. So the base of clients primarily were Medicare. So when we were at the legislative update, they talked about several times about this is an example of, Medicaid expansion would have helped Sacred Heart not close. And, they lost $56 million in 2 years, and it's hard to, see why they did, And there's been a lot of discussion about somebody else is gonna, made an offer. The discussions have been fluid, but there's no solid anything at this point. So we're just kind of still waiting. I don't know about your emergency room. You're probably right on the edge of people, coming this way and looking for services. So what we're, as a Northwest region in general, they've been really supportive in trying to help relocate, looking for resources. There's been 3 companies, and I can't think of them off the top of my head, that are expanding into the Eau Claire Chippewa area for behavioral health. I read something on Friday that said the majority, 95% of behavioral health staff have already been hired or are looking to be hired from these other programs. which is good and bad. We could have used a few, but, so I think we don't know the impact yet. It definitely is, it's already, I mean, if we don't have to use Winnebago to the extent that I'm anticipating, the budget, I don't know that we'll have any control over some of that. We really try to do everything we can, especially kids, not send them to Winnebago. What can we do? Is there a community support plan and things like that? Because that really is it's not the best place for them at all. It's so far away from their family, and it's a budget buster. Yeah, it's very, very costly. So what questions do you have?
And I don't think, they aren't really set up for kids, are they?
They have a kid unit, but it's not the, yeah.
Sure, have we had any elected officials from Madison come up and talk with you folks at all? And how that's going to be affecting us?
Not in any of the meetings I've been in. We've worked very closely with our state DHS staff. So I haven't been part of any of those, and I've been part of the mental health, substance use, and the children's conversations.
I just was wondering, so Winnebago's used for acute incidences of kids?
Yeah.
So they need acute care?
Yeah.
Not, and then there's not like the residential, that's somewhere else that they go for
Right,
that.
it's just they're short, and it would only be for if they meet that level for emergency detention. That would be
Okay.
the only
Oh,
time
only
they'd
then,
be.
okay.
Yep.
How many kids, I mean, how many kids go there now? I mean, do you have any idea?
We don't send them often.
Okay.
I don't.
Or how many kids would go
I don't know.
acutely?
Yeah, you know what? I'm not
Yeah.
exactly sure their capacity.
Yeah, okay. All right.
Yeah.
Okay. Thanks.
Any other questions? No?
I know, that's really a
To
bummer.
be continued,
I
I'm
know,
sure.
definitely. And as soon as we know what, if there is, I mean, hopefully somebody is going to open, the mental health part or the Ellie Phillips part. We need that for just our clients to be able to get to residential. So without it, they can't go.
Right.
Or they'll suffer to get to there, yeah, and it's.
Okay, well, let's stay on top of that.
Yeah.
And again, next topic on business items is a focus on mental health co-responders, and Shar, you're up
Yep.
for that.
So I actually kind of gave just a little bit of a history of how we got here. So the American Rescue Plan Act of 2021 offered us an opportunity to be creative with some of the areas that were most heavily stricken by COVID. And substance use and mental health were two of the areas that you could focus on. There were several, but those were the ones that we really looked at. And one of those was at that time, and actually probably just prior to that, there was a lot of focus on co-responders. What does that mean? Embedded social workers in law enforcement. And so we took a look I worked with River Falls PD, Hudson PD, North Hudson, New Richmond, and the Sheriff's Office were really the ones that we really were doing the planning with. And so at that time, Superior Police Department just had gotten a grant to have an embedded caseworker. And so we looked at that model, and there was a lot of things we liked about it, but that was just for Superior. It really wouldn't have worked for all of St. Croix County. So we really tried to think bigger. We talked with Rock County, and Rock County also had a team. They had one person with one officer, but they were embedded within behavioral health. And they explained the reasons why they wanted to do it that way, because as part of the statute, somebody from Health and Human Services has the ability to work with law enforcement they'll authorize the emergency but together they can make it work. You don't have to draw in one more person into the mix. And so the more we talked about it, we kind of had to do what we call the hybrid co-response. We have 2 staff that work, we have MOUs with all of the different law enforcement agencies, and they are called by, like they have radios, they have the police radios, so they both have call numbers, and law enforcement will say, if they're on their way to a call, hey, can you send BH 701 or BH 702? And they'll just automatically respond. They take a separate vehicle, so they take a county-owned vehicle, show up, usually about the same time as law enforcement, kind of debrief on what's happening, do an assessment. The law enforcement will assure that the scene is safe before they enter. And then if the co-responders can take care of whatever it is without law enforcement can leave. They know where they are, and they have a radio if they need to come back. And there has been a couple situations where law enforcement left, and they just called them, and they were back in just a lickety-split. So one of the things we were able to do is we were able to purchase soft uniforms. I have show and tell today. But so they have the St. Croix County logo. They wear them every day. They have different ones. We don't make them wear the same one every day. We've offered them more than one. But then they're easily identifiable when they're on scene. Like, who are you? And even if the law enforcement hadn't worked with them before, they know who they are with the coats that they have, and they have shirts and all that. They generally work the same shifts with the same officers. So they've had the ability to really build a teaming, a relationship, a trust between the two. So what we've done, I really went off script here. So implementation, so May of 2022, we were able to hire the 2 co-responders. Law enforcement offered training in CIT, that's the law enforcement language in crisis de-escalation, so they're all speaking the same language. They also offered the training with the police radio. So I gave like a quick example, because I think this is something that happens often. Like, what will happen is they'll get involved with law enforcement intervention because there was a call to 911 from somebody for welfare check. Law enforcement, if it's a mental health welfare check, will say, hey, send BH 701, and they'll send the right co-responder will meet them. They'll meet, they'll debrief, they'll meet together with the client, because that's essential when you're doing the crisis assessment. Law enforcement has to be able to assess that piece for dangerousness. They'll kind of discuss what's happening. They always have a mastered level staff available for consultation, so they'll call me, or they'll call Stephanie Greyer, or they'll call Natalie Radich and say, this is what's happening, boy, it doesn't really fit, or boy, this is what we're thinking. And to have somebody, because when you're out there on an island, sometimes that's very difficult to make those decisions. And there is never a textbook ever call, ever. There's always something in there that doesn't make sense, or it makes it a difficult call. They'll debrief with law enforcement. They'll talk with law enforcement to see what their take is, and very rarely, very, very rarely is there a disagreement. And if there is a disagreement, they have called me back and put me on speakerphone, and we just have a dialogue about what's happening and walk through it. And if law enforcement says, I really think that we can do a safety plan because of X, Y, and Z, we'll check it out with mom or dad or whomever, and really try to do the least restrictive, most appropriate placement for that client. So really, that kind of in a nutshell is what it would look like. Again, the law enforcement can leave if they don't need to be on site, and sometimes those calls can be very, very lengthy, depending on what is happening. Our co-responders can assist in coordinating a voluntary placement for a family, which is always the best if they need to be at the hospital and they're willing to go to the hospital. So they really try to coordinate that more than emergency detention is that's not our ideal goal for anything. So kind of looking at the metrics, I use the same metrics that I sent to Adam for the info that we're sending out. So 280 calls that we've had, and that's really it's a little bit over 2 years that we have. About most of them are with the sheriff's office, which makes sense because they're most times are covering the most rural areas in the afternoons when there isn't, Hammond isn't in working, or Roberts or Glenwood City, followed by New Richmond Police, and then Hudson Police Department. Locations, literally, they have gone everywhere. They've been in cornfields, they have been on the side of the road, they have been in homes, but most often they find themselves in the client's home. And then in the hospital, because oftentimes what will happen is if law enforcement comes in contact and that person is already in the hospital, they should show up at the emergency room. The emergency room calls law enforcement, and then they call them. So if they're looking at wanting to be in a hospitalization. And the most common outcome is a community support plan. Other things that I don't think are measurable, I wish I could take the really cool success stories and give you a metric, but I can't. And I wish I could bring in a client and say, please tell, this is how having somebody sit in your house for 2.5 hours and help work through a problem made a difference versus, other interventions. But things that we have really been able to do and see a difference is really being part of the St. Croix County residents in their homes, being available for them in evening hours as long as they need. Really due diligence to assure the least restrictive, most appropriate client-centered care is given, with client and public safety in mind, always in mind. In the increase in cooperation, collaboration, training, information, and expertise exchange and teaming between public protection and public health has actually been probably the coolest thing. I feel like there's been a really good connection between law enforcement and Health and Human Services. And then just the positive feedbacks from clients, from law enforcement, from hospital staff officials, of school, and then just about having them be available for a crisis. And St. Croix County Health and Human Services, law enforcement agencies, and individuals suffering from mental health and addiction crisis have greatly benefited from the mental health co-responder service over the past 2 years. We believe that establishing the sustained funding source for these positions beyond the current ARPA funding is essential. Co-responder intervention not only saves law enforcement time when responding to crisis, but provides client-centered interventions that prevent county residents from being transported to long distances to high-cost hospital settings. And in light of the HSHS closure, the co-responders will become even more valuable resources in really getting that local care option. And I can tell you within the last month, that has been a conversation with families. The reality is, knowing if your child is going to go to Winnebago, or if we can figure out how to get them to Children's, let's figure that out, because that's not necessarily where we want them to go. So what questions do you have? Yeah.
Thank you, Chair. Could we see, I'm sure there's probably some type of report that they have to file after an incident. Could we see some type of redacted version of that, protect their identity and just kind of see the instance of?
I could mock one
Sure.
and show you what it would look like. Yeah, so by statute, by the DHS 34, there's a couple different things. We have to do the crisis assessment, and there is a standardized screening tool that is utilized actually in most of the hospitals and in all of crisis. So I can show that, and then I can just have a mocked up what it would look like. Their reports are very factual because they have to use them for court. So
Sure.
this time this happened, this time this happened, this is my conversation, these are the hospitals I tried to contact, and then on the flip side of that is the follow-up piece. So after every single, regardless if they're at home or if they went to a hospital, there is a follow-up piece. So there is it's called linkage and follow-up, and there's another piece to that. So yeah, I can like maybe take a full, we actually have in our UAT, our user training, we have lots of duck families, like Donald Duck and Goofy and all the different ducks that we have in there. So I could probably find one and bring that and just share that to show you what it would look like.
Okay.
Yeah.
Thank you.
So this 240 calls, that's like just like emergency calls like you're going out now, but there's still the follow-up, and I'm sure sometimes people are in court giving for cases. So it's not just the 280 times or the 280 like things a year, I guess.
Yeah, that's just the
initial thing.
That's like the funnel that gets the process running.
Right. Yeah.
Yep.
And then how often are like just a percentage, a percentage, like guesstimate if that's if that's what you have, but are the officers able to leave the corresponder?
So most of the time they can, but most of the time they don't. so they, they're either, the places, it's a safe, and 58% or whatever I said, the community support plans, 58% of the time they could leave. But there's times that they're like, I'm gonna stick around.
Yeah, like they'd feel bad if they had judged it a little bit wrong, and
Or maybe it could go either way with some of that. Yeah.
So the co-responders, they're available just when outside of business hours? Is that when they're available?
So, at first, we had them start 3 p.m. We did like 3 to 1 a.m. or whatever, and there was more calls at like 11 a.m. when law enforcement would call and say, "Hey, you have a co-responder on?" And I'm like, "Not yet," And so then we shifted to noon and then we had noon and 3 p.m. and they were still like, no, really, we need that, like 10 o'clock would be better. So we actually have them come, we have one that comes in at 11 and one that comes in at noon, and then they do 10 hours, 12 hours. No, they do 10 hours. So whatever that is, maybe at 10 p.m. and 9 p.m. And so they really cover the time that is really busy. Schools need them, like 10, 11, 12. And you would think, like, logically, it seems like, well, when everyone gets home, but it's not. It's generally that middle of that day, and they're just called out. Sometimes, before they even get there, they'll call them, "Hey, can you meet me at so-and-so's?" And so there was another, when we went to the COSIP grant with the jail, Lieutenant Kufis had money to send us to DC, and I went to a co-responder breakout session, and they had said the exact same thing, like, "Oh, we thought everybody would be, in the middle of the night, or afternoons," and that they found that wasn't the case. And I think the more available they are, the more they're called because they're available. So there's not always something, on the scale of 1 to 10, a number 10. Sometimes it might be a 3, and they can just help alleviate that too. So they might get called more often just because they're more available.
And that's a good thing.
It is actually an upstream thing that we really want to happen. The schools really prefer it, and sometimes in one of the, a behavior room where you have some kids that have a little bit higher behaviors, just having somebody come in with outside eyes, it doesn't mean they're going to any sort of detention, but maybe working with the parent from the outside perspective versus the school trying to fix, because they can't, So they've been to schools quite often and trying to help strategize and crisis plan with the clients. One of the things I think that we've had a lot of, when they're at the house, they're doing like, commercial is not the right word, but they're like, hey, these are all the services we have. And I think we've gotten more CCS referrals because they've been in the home and they're like, hey, you know, we have this program that you can do some really hands-on things with the kids, and they can have some really alternative interventions that aren't talk therapy. And we've gotten a lot of referrals just from that.
Any other questions? Go ahead.
How is the capacity? You know, I anticipate that you're going to need more capacity with the HSHS closure. Is there sufficient capacity right now with 2, or?
I think, well, I can't think, there's very rarely a day that they don't get a call. I mean, maybe once every 6 months. So they're called out, and they overlap. So one works Monday through Thursday, the other works Tuesday through Friday. So, and their hours overlap as well. And sometimes they're both out at the same time. It's not uncommon. So capacity, what happens when they're not available, we use Northwest because we still pay Northwest to be our 24/7 backup. So we still have that piece and that coverage. I mean, it'd be great if we had a whole bunch more.
The other thing I would say about capacity is these are grant funded through the end of 2024. So that funding goes away. So without funding, the positions go away. So the capacity could result down to 0. We've added these 2 positions into the referendum that's going to be in April. So hopefully the voters will support that referendum, and these positions will be able to continue on then past that. But we're at a point at the end of this year that we don't know right now how they're going to be funded.
Yeah. And we've been strategizing, like, if just looking at our own budget, or, you know, what can we do to make it work? And, you know, unfortunately, it's like taking a position from one place and putting it somewhere else. But, we just really believe that these are essential, I think, really, to make sure that we're providing really good service. It's a really great connection with law enforcement. That's the other thing.
Yeah. We tried a number of positions with the ARPA grant dollars, but you'll notice that these are the only 2 that we're asking for in the referendum, because this is the priority.
Yeah.
These are very special, very important positions that we really do need to continue on, because they have a downstream effect. They have an impact on our law enforcement's capacity. So it has a big impact for the county.
Anything we can do to keep them from having to go to out of home placement
Yes.
is
Yes.
upstream is the way to go.
Absolutely.
Yeah, I just to follow up on that, everyone I've talked to, from, you know, any deputy, investigators, the sheriff, obviously my brother's in the DA's office, and some of his coworkers, everyone is just like, these need to stick around.
Yeah.
So they are definitely, there was some, I guess, some, I don't know, not the apprehension's the wrong word, but a little bit of doubt, I guess, on how well this would work, but it seems to be pretty beneficial for all involved.
I think thank you for saying that. I think part of it too is their personalities. They're just 2 really good fits. One has, you know, he has background working in corrections, so he has a very, you know, correctional sense to him. The other one is he was a salesman, and he's really good with humans, you know, he yeah, well, they're both pretty funny, actually. They're probably watching, so I have to say that. But they're just really flexible, and I think that was a big piece of that very beginning, where we drew law enforcement in, and they helped us interview. And actually, I'm not going to lie, one of the chiefs said, if you don't hire him, I'm going to. So, you know, it was really important for them to really like them. And yeah.
Any other questions? Thanks, Shar, very much.
Thank you.
That concludes the business items. Any requests for future agenda items? Okay, we won't have an agenda. I doubt it. Announcements and correspondence, anything there? I guess the date of the next meeting will be March 20th at 5 PM. I'll adjourn the meeting, and welcome Dr. Finley again.